Could you look at my scalp? It's been really dry and itchy, and I think I have psoriasis.
Oh, I think we need to have that looked at. Psoriasis is the topic I chose for this project. A good starting place to learn about psoriasis is beneath the skin surface. Many people think of psoriasis as just a skin condition because of where you see and feel the symptoms. Take a closer look and you'll see psoriasis is a chronic disease believed to be the result of several factors, including an overactive immune system. The exact cause of psoriasis is still unknown. However, we do know that inflammation inside the body may cause the symptoms of psoriasis, including itching, red plaques that you see on your skin. There are 6 different types of psoriasis: plaque psoriasis, Goudet psoriasis, pustular psoriasis, inverse psoriasis, erythrodermic psoriasis, and psoriatic psoriasis. The risk factors: in most cases, people develop psoriatic arthritis after developing skin symptoms of psoriasis. However, it is possible that psoriatic arthritis to develop before the skin lesions even occur, making an accurate diagnosis difficult to establish. People between the ages of 30 and 50 are most likely to develop psoriatic arthritis or psoriasis in general. However, it can set in at any age. People with family history of psoriasis or psoriatic psoriasis are more likely to develop the condition than those without. While any part of your body can be affected, psoriasis plaques most often develop on your elbows, knees, scalp, back, face, palms, and feet. Like other autoinflammatory diseases, psoriasis occurs when your immune system, which normally attacks infectious germs, begins to attack healthy cells instead. Psoriasis is a complex, multifactorial disease that appears to be influenced by genetic and immune-mediated components. This is supported by the successful treatment of psoriasis with immune-mediated biologic medications. The pathogenesis of the disease is not completely understood. Multiple theories exist regarding triggers of the disease process, including infectious episodes, traumatic insult, and stressful life events. In many patients, no obvious trigger exists at all. However, once triggered, there appears to be substantial leukocyte recruitment to the dermis and epidermis, resulting in characteristic psoriatic plaques. Specifically, the epidermis is infiltrated by a large number of activated T cells, which appear to be capable of introducing keratinocyte proliferation. This is supported by histologic examination of a immunohistochemical staining of psoriatic plaques, revealing large populations of T cells within psoriatic lesions. One report calculated that a patient with 20% body surface area affected with psoriasis lesions has around 8 billion blood circulating T cells, compared with approximately 20 billion T cells located in the dermis and epidermis of the psoriatic plaques. Ultimately, a rammed up, degenerated inflammatory process ensues with a large production of various T cells. Many of the clinical features of psoriasis are explained by the large production of such mediators. Interestingly enough, elevated levels of TNF are specifically found to correlate with the flares of psoriasis. Clinical manifestations are the psoriasis plaque. Common triggers are exposures to cigarette smoke, infection or skin wounds, severe stress, cold weather, drinking too much alcohol, or taking certain medicines. The treatment options: topical corticosteroids are prescribed for treating mild to moderate psoriasis, vitamin D, topical retinoids, salicylic acid, light therapy, sunlight, UVB therapy, oral or injected medications, methotrexates, retinoids, drugs that alter the immune system. And in most cases, diagnosis of psoriasis is fairly straightforward. With a physical exam, your doctor can diagnose psoriasis by taking a medical history and examining your skin, scalp, and nails, and then a skin biopsy. Thank you so much.